Welcome to Emergency Chaos, where we provide tips and tricks to make you a better nurse. Today, we will be going over some big gun medications, vasopressors. It's going to be a long one, but it's such an important topic that I did not want to miss anything. We will discuss what vasopressors are, what receptors they work on. We will discuss each in detail, including dosing and how to titrate them, followed by going over how to make a dirty epinephrine drip and how to make a norepinephrine drip. Then we will go over what push dose pressors are, and ultimately we will end with specific tips for nurses who are the ones starting and titrating these medications. So, vasopressors, also commonly known as pressors, are potent medications that constrict blood vessels, ultimately increasing blood pressure with the goal of restoring tissue perfusion in very hypotensive patients. Besides vasoconstriction, they can also affect heart contractibility and heart rate, but because of their strong and primary effects on blood pressure, they are often just referred to as vasopressors and not inotropes. We will discuss the main inotrope used, which is Dobutamine, towards the end of the lesson series. Before we go on, we have to go over the different receptor sites that these pressors work on. Alpha receptors are found in vascular walls, and when stimulated, cause vasoconstriction and ultimate increase in blood pressure. Beta 1 receptors are found in the heart, and when stimulated, cause an increase in the strength of contraction of the heart and an increase in the heart rate. Beta 2 receptors are in the lungs, and when stimulated, lead to bronchodilation as well as vasodilation. And then we have V1 receptors, which are also located in vascular walls, and as you guessed it, when stimulated, lead to vasoconstriction and ultimate increase in blood pressure. So, are vasopressors important? Heck yeah, they are, right? As you can just ask any ER nurse or ICU nurse how often they use vasopressors and how it feels watching the blood pressure come up after it's been in the dumps. It's important for you to know what pressors are, because the time will come when you are the one starting and titrating these big gun medications. And by golly, you better know your stuff, because you can kill someone if you are not careful. All right, so let's get into them. So, norepinephrine, commonly known as Levofette, is going to be the go-to pressor. It has potent alpha effects with slight beta 1 effects. It's the pressor of choice for septic shock, and it's also commonly the first line agent for neurogenic, cardiogenic, and obstructive shock when needed. Note that it's also used in hypovolemic shock, however, only when the patient has been appropriately volume resuscitated, because if they have not, it will cause severe ischemia. What they need in hypovolemic shock is fluids or blood products. Why can it be used over dobutamine in heart failure? Well, although dobutamine primarily affects beta 1 receptors, leading to greater contractility, it has vasodilatory effects, leading to unpredictable blood pressure responses. So if your patient is in cardiogenic shock with a low blood pressure and you start dobutamine, it can lead to an even lower blood pressure. So Levofette tends to be the go-to pressor when a pressor is needed. The concentration of Levofette is typically 4 milligrams in 250 mLs of normal saline, but it can also be 8 milligrams in 250 and even up to 16 milligrams in 250 mLs of normal saline. So if you have to make a Levofette drip, grab a 250 ml NS bag, 4 milligrams of Levofette, and inject into the bag. Of course, use a filter needle if it's a glass ampule, and clearly label the bag with the medication, the dose, the date, and the time of initials. The onset of Levofette is usually 1 to 2 minutes, which is why it's very important to give it time to work instead of going crazy, bolusing, or titrating the medication too high too fast. The range changes from facility to facility, so check your own facility's range. However, it's typically 2 micrograms per minute to around 40 micrograms per minute, with an initial starting dose of 2 micrograms per minute. I've seen ranges as high as 200 micrograms per minute and start doses at even 8 micrograms per minute. And then going over how to titrate, usually you're going to be titrating by 2 micrograms every 3 to 5 minutes. But know that titrating is sort of an art form. So for the time being, while you're training and precepting, do as your preceptor says when it comes to titrating Levofette. Now, let's get into Vasopressin. It's a potent V1 agonist, which, as we remember, is located in arterial smooth muscle, leading to a vasoconstriction and ultimately rise in blood pressure. It is never going to be a first-line agent as a pressor. However, it'll be the go-to, especially for septic shock after norepinephrine, or Levo for short, as we've discussed. Essentially, what Vasopressin does is that it lets Levofette work a little better and simultaneously also increases blood pressure. Note that it does work pretty well in acidic environments compared to other pressors. So it does work well in acidotic environments compared to other pressors. So for septic shock, after you are constantly titrating Levo up and are getting decently high on the range that we discussed, you let the providers know and suggest adding Vasopressin on. It can take up to 15 minutes for it to start working, but when it does, you'll note a big difference in the patient's blood pressure. Key points with Vasopressin is that you do not titrate it. You start it and you just leave it. When you are going to take it off, you simply just shut it off. You do not titrate down, you just shut it off. The typical dose is going to be 0.03 units per minute. Concentration-wise, it's typically 20 units in 100 mLs of normal saline. So let's say you had to mix it yourself, you do exactly that. You place 20 units of Vasopressin in a bag of 100 mLs of normal saline. And again, you clearly label the medication with the date, the time, and the initials, and you write it clearly that it's Vasopressin in there. Other facts that I want to mention about Vasopressin include that it's used for diabetes insipidus since it has an effect on the kidneys to retain water. Also, it can be a substitute for epinephrine in cold situations, although I've personally never come across this situation. So now let's get into talking about epinephrine. It pretty much affects every single receptor that we talked about, alpha, beta 1, and beta 2. So it increases blood pressure, increases contractility, increases heart rate, and has bronchodilatory effects. It's going to be the primary agent that we use in full arrest, so essentially when a patient is pulseless. Then it's going to be used as a vasopressor drip for a continuous infusion in shock related to anaphylaxis. Epinephrine is also preferred in any type of shock when there is an inadequate increase in heart rate. So both the BP is low and the heart rate are low, instead of the heart rate increasing as a compensatory mechanism. So as I said, it's going to be preferred in any type of shock when there is an inadequate increase in the heart rate. Doesn't matter which type of shock, but that's what I've seen it. It can even be used before Levo and Vaso if the heart rate does not respond as a compensatory mechanism and it doesn't go up. Besides these situations, epinephrine is typically going to be an add-on after nothing has worked, especially when it comes to septic shock. It will be used as an add-on after Levofette and Vasopressin. The onset of epinephrine IV is going to be 1 minute. The concentration is typically 1 milligram in 250 mLs of normal saline, but I've also commonly seen 4 milligrams in 250 mLs of normal saline. There's also what's called the dirty epi drip and push dosing of epinephrine. However, I'm going to be talking about those specific ones on a later slide in the video. The range of epinephrine for a drip, it's going to be 0.5 to 2 micrograms per kilogram per minute with a typical start dose of 0.1 micrograms per kilogram per minute. And then typically you're going to be titrating it by 0.1 mics per kg per minute every 3 to 5 minutes or so. Or actually, sorry, it's going to be up to 20 minutes. And then we're going to talk about the complications related to pressors on a separate video. But just know that with using lactate, it can increase with using epinephrine, it can increase lactate levels. So if the lactate goes up crazy when your patient is on an epin drip, just know that that might be the reason why your lactate is going up on your patient. Now, let's get into talking about phenylephrine or Neosynephrine. Phenylephrine has pretty much just pure alpha activity, right? So it's only going to work on increasing SVR and increasing blood pressure. It's typically going to be, again, as an add-on agent, especially for septic shock and others. It's going to be add-on after Levo has been added, after Vasopressin has been added, and even after epinephrine has been added, right? It does have an onset of 1 minute, concentration of 50 milligrams and 250 mLs of normal saline, and a typical range of 10 mics per minute to 200 mics per minute. You're typically going to be starting it at 100 mics per minute, and you're going to be titrating by 25 mics per minute every 3 to 5 minutes. Just know that as well as epinephrine, Neosynephrine also has push dose. It can also be used as a push dose vasopressor, but we're going to be going specifically over the push doses for epinephrine and Neosynephrine on a later slide. And then one thing that you want to keep in mind is that with Neosynephrine, you can have a reflex bradycardia, right? Because if you increase the blood pressure really high and only the blood pressure, the body can react at times by decreasing the heart rate to try and bring the blood pressure down, because the body's not going to know that we're giving a medication to increase just the blood pressure. So it says, hey, my blood pressure is really, really high. Let me do what I can to bring it down. And one of the ways the body does this is by decreasing the heart rate. So just keep in mind that with phenylephrine or Neosynephrine, you can have a side effect or complication of reflex bradycardia. Now, let's go on to dopamine. Dopamine acts on beta-1, alpha, and works to improve renal perfusion. Dopamine is unique in a sense that we know what receptor it hits, but a lot of the times we are pretty much unable to determine the effects that it's going to have on our patients, since different doses of dopamine hit different receptors. So for this reason, at least in the ER, it's not really used as much, since we can use Levofette or epinephrine and we know exactly what we're getting with those two medications. Dopamine also has more undesirable side effects compared to Levofette or epinephrine, so that's why they get used more often. However, just so you know, dopamine has an onset of 5 minutes. The concentration is typically 450 milligrams in 250 mLs of normal saline, with the range of 2 to 20 micrograms per kg per minute. The starting dose would depend on what it's being used for. So below 10 mics per kg per minute, it's going to have effects on beta-1 receptors plus increase in renal perfusion. Then above 10 mics per kg per minute, it's going to have effects on alpha receptors, increasing blood pressure. And then you would titrate it by 1 to 4 mics per kg per minute. But again, as I said, we do know the receptors that dopamine is supposed to hit and at what rates but a lot of the times we just can't really pinpoint what effects it's going to have on our patients. So in the ER, at least, we try not to use it as much because we have other pressors like Levofette or epinephrine that we can calculate on a more structured basis what their effects will be on our patients. And now let's talk about dobutamine, right? So dobutamine, different from dopamine, is dobutamine is the main inotrope you're going to see in the ER. So inotropy is just a fancy way of increasing muscle contraction. And in the heart's case, it increases contractility. It's going to be a harder pump, right? So dobutamine has effects on beta-1, beta-2, and alpha receptors. However, the main effects of dobutamine are going to be on beta-1, resulting in increased contractility with very minimal increase in heart rate. So again, just beta-1, but primarily with the increase in contractility. Because it does have beta-2 effects, it also leads to vasodilation. And it can counteract the alpha effects that it has. So even though it has beta-2, it also has some alpha effects, so they kind of counteract on each other. However, you're going to note that at times your blood pressure, when you do start dobutamine, will actually go down, okay? So dobutamine has typically been used in cardiogenic shock and heart failure. However, I've had some recent discussions with providers while I was making this video, and the analogy that was given to me is that you don't want to whip an old heart to work harder if it's already tired and damaged, right? So taking that into consideration, even though I just said that some providers will still order it, and I've seen it be used as an add-on agent, especially after Levofette and Vasopressin in septic shock. It works decently. However, typically epinephrine is the one that gets added on instead of dobutamine to give the heart an extra kick in septic shock. The onset can be as much as 10 minutes with the concentration of the medication of 500 milligrams and 250 mLs of normal saline. The range is 2 to 20 mics per kg per minute, with again a typical start dose of 2 mics per kg per minute or per hour, and titrating by 2 mics per kg per minute every 15 minutes. Now let's go into how do we make a dirty epinephrine drip. So a dirty epinephrine drip is just 1 milligram of epinephrine in a liter of normal saline. And typically we run it just wide open without a pump. Even though I've advocated for the importance of being careful with pressors, why are we going to run it wide open? Well, a dirty epi drip is going to be used in critical high stress situations where a lot of things need to happen simultaneously to save your patient. For example, in anaphylactic shock, or when your patient is nearly dead or heading there very rapidly, right? Those are going to be the high stressful critical situations that I'm talking about. So a dirty epi drip is easy to make and you can do it rather fastly, which is crucial in these high stakes situations, right? And most importantly, with the dirty epi drip, it's going to buy you time to get other more permanent measures in place. For example, is starting an actual epinephrine drip as we start, putting it on a pump and all that stuff, but that takes a while. So this is going to be something that you can do super quick to give you and buy you some time so you can do these other permanent interventions. So in order to make it, you're going to grab an amp of epinephrine from your crash cart, which will contain 1 milligram of epi. Then you're going to inject it into 1 liter of normal saline. You're going to label it, you're going to shake it, and then you're going to run it wide open. Just note that even if you run it in an 18 gauge in the AC, the rate is only going to be about 20 to 30 mics per minute. So it's not going to be a deadly dose. It's going to be a little faster than normal, but it's just for those few first minutes when your patient is crashing, and it buys you time to get those other permanent interventions in place that we talked about. So now, how do we make a Levofette drip? So we know that we can't wait for pharmacy to deliver our pressors, especially if they're not loaded in the Pyxis and our patient is crashing, right? We must know how to make the pressors ourselves. So specifically with Levofette, we have to know how to make it because we use it so often. So to make it, you're simply going to get 4 milligrams of Levofette, which it should usually be in your crash cart, or at least should be loaded in the Pyxis. Then you're going to inject it into a 250 ml bag of normal saline. And of course, you're going to label it, you're going to shake it, and then get it going for your patient, right? Because we cannot wait for a pharmacy to send up these medications when our patients are crashing. Now let's talk about push dose pressors. In other words, so push dose pressors, in other words, is essentially a small bolus of a pressor, and it's given in like an emergency situation. So a small bolus is given in an emergency situation. There's going to be 2 agents that we use for push doses for pressors, and these are going to be phenylephrine and epinephrine. So first, let's start with phenylephrine, or Neo for short, right? So its primary use is going to be for hypotension related to an agent or another medication that was given during specific procedures. So for example, with procedures related to rapid sequence intubation or unconscious sedations, because you know that the medications we give to knock somebody out during a conscious sedation or in intubation, they can lower the blood pressure. So we can give a push dose of phenylephrine to bring the blood pressure back up. And then you're going to note that it should not be given if the patient is also bradycardic. And we just talked about this. We do not want to give it if a patient is already bradycardic, because Neosynephrine can cause bradycardia. So we don't want to use it if the patient is already bradycardic to bring someone's blood pressure up, because it can lead to further worsening of their bradycardia. So to make it, you're going to draw up 10 milligrams of phenylephrine, which will usually be in 1 ml. Then you're going to inject this 1 ml that has 10 milligrams of phenylephrine into a bag of 100 mLs of normal saline. This is going to give you a concentration of 100 micrograms per ml in this 100 ml bag, right? So your ER provider will be the one administering the push dose of phenylephrine, and they're typically going to administer 50 to 200 mics of phenylephrine as needed. And if you remember, as I just said, you're going to have a concentration of 100 mics per ml, and your provider will administer 50 to 200 mics as needed. So 0.5 to 2 mL is what they're going to be administering. However, note that a lot of ERs are going away from the staff missing their own phenylephrine doses because there's been a lot of errors in the past, and patients have ended up severely injured or even dead. So a lot of progressive hospitals will have pre-made syringes of phenylephrine that are specifically made for a push dose. So just keep that in mind and figure out what your facility has. And if you are going to be making the bag to use as a push dose, be extra careful that you're doing everything right. Okay, now let's go over epinephrine. A push dose will most likely be given in a crashing patient. So epinephrine, a push dose, will most likely be given in a crashing patient, especially one who is about to arrest, since epi again has effects on alpha, beta 1, and beta 2 receptors. So to make it, you're going to grab a flush or a 10 ml syringe with normal saline. You're going to take 1 ml out, leaving only 9 mLs in this syringe, right? Then you're going to grab an epi-amp, which has 1 milligram in 10 mLs, and you're going to inject 1 ml of the epi-amp into this flush. Now, this will give you 10 mLs with 100 micrograms, right? Or 10 micrograms per ml. And then your provider is going to administer 10 to 20 micrograms per dose at a time as needed for your crashing patient, right? And again, this can be made very easily, and the more you do it, the faster you'll be at it. A lot of the times your providers will do it themselves, but I like knowing how to do these specific things because let's say that there's only one provider, they're busy putting in a central line, they're busy putting in an A line, or they're busy intubating your patient. You have to know how to do these things so you can get it ready and give it to them. And again, as I keep saying, the more you know, the better a nurse you are, and the safer you are, and the better you are for your patients. So, complications. Pressors are the big guns of the medical world. Although they can save lives, they do come with a variety of risk. A lot of them, if extravasation occurs, tissue necrosis also happens. Patients are also placed at a higher risk for developing arrhythmias and overall ischemia to most organs, including the periphery, the heart, pretty much any organ in the body. So please follow your preceptor's teachings and guide and follow your own hospitals and organizations' protocols when you're using these. And don't just bolus a pressor, even though your blood pressure is crappy. Don't be tempted to do that because you could seriously injure somebody or kill somebody. But definitely just be extra safe with these medications. So now let's get into the must know, right? The must know, the essentials for nurses, right? If you only get this out of watching this video, I'm going to be extremely happy because you're going to be safe. And I hope you made it all the way to the end of the video to learn about these. So in emergency critical situations, don't be shy. It's okay to start vasopressors peripherally, especially Levofette. Yes, you must get a central line, but in a sick crashing patient without a central line, it's okay to start the vasopressors peripherally for the short term while the providers work on a central line. Next, pressors are compatible with each other. So again, in situations where your patient is crashing and you don't have many access, you don't have a central line, they can go together. As was said to me, vasopressors work and play well with each other. Of course, I want you to verify with your own pharmacy or pharmacist if the way your pressors are mixed, if they're compatible with each other. You always must have your next bag of whatever pressor you're using ready to go. You do not want to be caught with an empty bag because your patient's blood pressure will tank, and it's going to feel like an eternity before you get the next one ready to go. So always, especially if you're running at a high rate, have the next bag of whatever vasopressors you're using ready to go. Keeping this in mind, the next tip is going to be very important. You must learn how to make your own norepinephrine or Levofette drip an epinephrine drip, and a vasopressin drip. Again, in an emergency situation, if your Pyxis is not normally stocked with them, you do not have the time to wait for pharmacy to make it and send it up. You must get it ready yourself. You got to be a cowboy, you got to be a cowgirl in the ER, and you just have to get things done. So you have to learn how to make these yourself. So quick tips for vasopressin, as we discussed, you're not going to titrate it. You're simply going to start it and leave it usually at 0.03 units per mg. And also most pressors kind of suck in severe acidosis, except vasopressin. It works pretty decently actually. Next is that you need to label all of your lines. You need to be able to quickly determine what is running in each line. So you do this by labeling close to the patient and close to the pumps, so you can easily grab any tubing and say, oh, this is what's running in this line. Again, you are going to be tempted to give your patient a fat bolus of whatever pressure that you're using if their blood pressure is shitty over shitty. However, don't do that, because you're going to cause acute hypertension that puts stress on the heart, leading to increasing oxygen demand. It leads to left ventricular dysfunction. It leads to ischemia all over the body and a bunch of other stuff. So don't be tempted to bolus like crazy your vasopressors, because you could kill somebody, right? So keeping all of this in mind, when you do titrate, give your pressors time to work, right? We talked about the onset, so make sure you give them the time to start working instead of just titrating up. And then overall, little by little, as the time goes on and as you start using these pressors more and more, your sense for them, the art of titrating, will build little by little in you, and you're gonna get better with them, right? And then, of course, do as your preceptor says, especially in critical care situations, since they've been around the block and they know what's up with the patients and with the pressors, right? Finally, for the essentials, if you are starting a second pressor, you need to be asking your providers to get an A line after they place a central line, right? The arterial line will provide a real-time blood pressure, and it's much easier and safer to titrate with an arterial line. So in order to facilitate the placement of a central line and an A line for your patient, gather all of the supplies necessary for each and essentially just bring them to the bedside, or pretty much hand them over to your provider and say, hey, can you just get this going, please, right? Wow. That was a pretty long lesson, and I'm glad we got through it. If you're still here at the end, thank you. Now let's get into the question of the day. So what is the treatment of DIC, or disseminated intravascular coagulation? Wow, that's a tongue twister. Again, what is the treatment of DIC? And as always, the answer will be at the bottom of the description text. I think that being a good ER nurse depends a lot on your experiences and taking the time to look up and familiarize yourself with topics that you don't fully understand. I've listed my favorite ER nursing related books in the description, and I believe that you can benefit greatly from reading them. So I recommend that you check them out. And then as always, keep learning. You'll be a better nurse, you'll be safer, and ultimately you'll be able to save more lives. If you enjoyed and learned something from the content today, I would really appreciate a like and a follow, or share it with your friends, share it with your other preceptees. And if anything comes to mind that you would like me to cover, please comment below. And if you want to further support, I have stickers and shirts up on Redbubble for ER nurses, so check them out if you get the chance. If not, I just thank you for watching the video, and I hope you learned something from the video today. So as always, teamwork makes the dream work, and here at Emergency Chaos, we are proactive, not reactive.